Good morning, Casey.
Morning.
It's my honor to introduce the next speaker. He is our good friend, and he's the Vice President and Chair of the National Investigator of Clinical Epidemiology and Research of Society of Intensive Care Medicine Singapore. We are happy to build close cooperation with SICM. He's the head of Division of Respiratory and Critical Care Medicine in National University Hospital, Singapore, and he is also the Director of Research Residency Program of National University Hospital, and he published several important studies in outstanding critical care journals like Intensive Care Medicine, Chest, and Critical Care. He contributed a lot in the campaign against COVID-19 critical care in Singapore, and he will share it to us today. Please join me in welcome Dr. Choong.
Thank you. 大家中午好. Thanks everyone, and thanks Tony for the invitation to share about critical care for COVID-19 in Singapore. These are my disclosures. And for this talk, I'll cover 5 points. The first would be ICU organization in Singapore. The second would be the use of personal protective equipment. Third would be a few short words on isolation and de-isolation practices. And the fourth and fifth would cover our intubation and ECMO practice. We in Singapore have been extremely lucky to have only experienced a surge of COVID-19 cases in May, June, and July. And even among all these cases, most of them actually affected the fairly young population among the foreign workers in the dormitories. So these foreign workers are actually workers that come to Singapore to work in industries like the construction industry. So only about 0.3% of cases in Singapore were actually admitted to ICU. And among the patients in ICU, only about most of people survive. And in comparison to usual sepsis, we didn't experience a markedly increased mortality. So we could actually have the opportunity to practice ICU care very conventionally. We didn't have any ICUs that were overrun. Our resources were never overwhelmed. And we basically admitted patients and decided on care based on the usual ethical concepts of benefit versus futility. We never needed to ration healthcare, thankfully. So in terms of ICU organization, we actually use the conventional considerations like creating space for ICU, staffing, supplies, and of course, drawing up policies and standards that were relevant to COVID-19. Very thankfully, because we had enough resources, we could actually split our teams into parallel teams. So these teams actually don't mix. One team would be called the clean team, and these included folks who will care for patients without COVID or proven not to have COVID. And the so-called dirty team or the pandemic team would be a team of an equivalent number of people with same amount of resources to take care of patients who are either having COVID-19 or who are suspected to have COVID-19. So we actually have a lot more people suspected to have COVID-19 than people who are proven to be during the pandemic itself. So both teams don't mix. There was almost no chance of cross-transmission, at least in the current setting. So I think beyond infection control, ICU organization actually extends also to designing policies and practices, and also contingency planning for safe transports. We also took care of dissemination of information. I'll elaborate more on these on the further slides. Also, resuscitation and code blue responses need to be designed around the concerns around COVID-19 infection as well as transmissivity. Advanced ICU services like bronchoscopy needed to be tweaked. And also we need to pay good attention to healthcare worker well-being. I think it's not just because we had a bit of increased workload during the COVID-19 pandemic, but also because there were other restrictions placed on healthcare workers. For example, our leave was frozen. We were not allowed and still are not allowed to travel overseas of us transmitting to our family members. So there's all these concerns actually weigh down heavily psychologically on people, and we do need to actually address them quite upfront. Well, in terms of infection control, beyond what most of the other speakers have already discussed about the duty in isolation facilities. We additionally allowed isolation teams, right, to have this 2 week off-duty observation period. So what does this mean? It means that if someone in the dirty team or the pandemic team needed to see patients in the outpatient clinics, in the clean areas, then we actually put a 2 week observation off-duty period whereby these staff actually did other things, for example, research, they did basically office duties, administrative duties, but they didn't come into any patient contact. And this created a condition whereby people were confident that all doctors, all staff in the clean areas truly did not have COVID, even asymptomatic COVID. And this was very helpful, to put everybody at ease, especially our patients and especially society. Well, in terms of transport, apart from what has been discussed, especially in the STEMI talk just now, we also took care of bystander safety. Just like what we did for STEMI in Taiwan, we also had pre-planned transport routes, not only within the hospital from the ED to the ICU, from ICU to the, for example, radiology suite. We also had, pre-dedicated transport equipment, staff, and also personnel and routes when we needed to transfer patients between ICUs in Singapore. So why is this important is because there were only 3 ICUs in Singapore that provided ECMO services, and any step up of treatment required transfer from the other ICUs to these 3 ICUs. This was just for ECMO, but there are other instances of transfer for more advanced care also. In particular, when we talk about bystander safety, the security teams need to deploy along the whole route so that, any bystanders, any people, unsuspecting visitors, for example, they will be moved away from these areas to minimize the risk of transmission along the routes. Well, post-transport decontamination was also drawn up very strictly. We made sure that every equipment, all vehicles, all personnel were thoroughly decontaminated before returning to their areas of work. In terms of dissemination of information, this was really, really critical. I think now we have great clarity about COVID-19, but at the start of the pandemic, for example, there was a lot of information coming through the media, coming through preprint, servers, and coming through the conventional EBM routes. And as you've heard Prof. Dellinger, this can be extremely, extremely confusing on top of rapidly changing policies and regulations in a hospital. So for example, lab testing, whether you can do it or not, sometimes could change about 3 times a day. So how do we actually overcome all of these? And how do we overcome, the great threat of confusion? We actually set up secure web messaging groups, for example, through some, at least some protected WhatsApp sites, and also some of our own internal groups through this thing called Tiger Text, whereby we actually disseminated information and allowed people to also ask questions about each other to clarify things. So this, I think, helped a lot to relieve a lot of confusion. Code blue responses were also important to take into account. I mean, in Singapore, we did have the fortunate situation whereby we had access to PAPR, just like in Oregon. So during resuscitation, many people actually opted to put on PAPR on top of the standard PPE. But this actually impeded communications. It was quite hard to talk when the blower is actually switched on. So we put on, we had devices like printed cards for communication. And also, people didn't want to come in and out of the isolation room freely for fear of transmitting infection, and also to preserve and conserve PPE. So for communication between and outside, within and outside of the isolation rooms, staff and patients actually could use walkie-talkies and messages on whiteboards to communicate. So this actually helped a lot in terms of transmitting information. Advanced ICU services were tweaked a little bit. For example, bronchoscopy, we changed almost entirely to disposable bronchoscopes during the COVID-19 pandemic, especially for patients suspected or confirmed to have COVID-19. So this increased cost a little bit. I think they are probably not very environmentally friendly, but at least at the start, we eliminated any risk of transmission. But slowly we are moving back into this reusable scopes. Now for psychological stress and burnout, I think we have heard a lot from other speakers and also from our own general knowledge that we need to share a lot, give a lot of psychological support. But actually physical support, like just provision of meals and drinks, were very important. So we took care of all the meals, breakfast, lunch, dinner, tea time, even supper breaks for all staff that were in the pandemic areas. And this allowed the staff to not only have physical well-being, but also reduce their need to actually travel out of the isolation areas to buy their own food. And I think we have been very fortunate that the whole society in Singapore was aligned to the COVID fight, and many companies actually donated and supplied and sponsored special food and drink for all staff. So we are really very thankful for that. But nonetheless, we do have plans in case the situation spirals out of control. Nobody could predict how the COVID-19 pandemic would go on. So therefore, we actually had plans for surge capacity. I think we'll be discussing more about this in the afternoon. But for us, we generally identified areas that would be converted to ICU when the need comes about. I think obvious areas are like OTs and post-anesthesia units, but other areas like the general isolation wards were also identified. But this is just one concept of space, right? So in terms of ICU capacity, we do need to take care of staff and supplies. And we created very rapid informational and also educational programs and also simulation programs to help staff from these so-called non-ICU areas to be trained in ICU techniques, at least basic ones like ventilator strategies, like prone positioning, as well as hemodynamic control. Equipment also has to set aside for these places. For example, the ventilators, for example, some of the renal replacement machines, we set aside some extra ones for these non-places as well. We also had some draw plans to manage limitations, yes, in case. I mean, we're imagining the worst case scenarios all the time. So just in case, even our surge capacities were overwhelmed, and even if we have drugs, but we are short of them, we had plans written up, and we have actually published some of these to basically give us alternative drugs to use when our primary drugs have run out. So this is an example of fentanyl, for example, running out. What do we use? We have considered use of non-opioid analgesics and so on and so forth, with the special considerations and contraindications listed in this article. For PPE, we have been careful to follow on with the World Health Organization requirements. So these are the standard 4 which we have heard of. But on top of that, we emphasize a lot of strict hand washing and cleaning of equipment. But beyond that, I think a lot of staff actually, because of fear of patient transmission, actually went beyond the WHO recommendations. And generally, most people put on caps, put on shoe covers. Actually, a substantial proportion of people, as compared to other Asian countries, use PAPR. So our use of PAPR was actually quite high, though it was not made mandatory, but many people actually use it for, for safety. And indeed, we are very thankful that only about less than 2% of all healthcare staff were actually infected. And most of these infections were identified to be transmitted from the community rather than from within hospital. So this gave the hospital staff a lot of confidence to continue working in the front line. Well, we were very careful also for ICU patients to only nurse them in negative pressure rooms, and this avoided really a lot of transmission outside of them. And we only de-isolated patients if there were two negative samples on PCR testing from either the nasopharynx or on the ETT. And these two samples had to be taken on separate days, spread about 24 hours apart. We have some thoughts also originally on the use of high-flow nasal and non-invasive ventilation, but we actually avoided them, not just because we had enough ventilators, but we were very afraid of aerosolization. And I think this has some founding because at least from a group in Italy, this is from Stefano Nava's publication, that when we use NIV in the so-called respiratory wards, they had 11.4% of their healthcare workers being infected. So I think there is some concern. We probably were quite aware of this. And we also were aware that having prompt and timely intubation might not be that bad a thing after all. So this is a study, a small study, showing that among patients who had so-called delayed intubation using high-flow nasal and NIV before intubation, right, there was actually no really marked increase in survival, for example. And in patients who had intubation, direct intubation without the use of HFNC or NIV, there was actually no real increase in number of ventilator days or ICU days. So really not much resource differences either way. And I think our policy was worked out for us at least. What did we actually realize quite early on in the pandemic was that many of our patients actually spend a long time on mechanical ventilation, especially with COVID-19 pneumonia. So we were aware that while we had to use antimicrobial use to treat concurrent bacterial infections, like what the previous speaker has mentioned, we avoided unnecessary escalation to broad spectrum antimicrobials if the cultures are negative, because this would just promote antimicrobial resistance. And we also avoid rushing into using off-label or unproven or experimental drugs for that matter. Of course, all these long duration of mechanical ventilation impacted upon resource planning. We actually catered quite a lot of resources. We probably overestimated a little bit, but I think this is okay when we are doing pandemic planning. So we set aside extra bed capacity, ventilators, medications, and even train more to deal with a potential surge of ICU cases. Nonetheless, we did try to extubate everybody as early as possible. And during extubation, we didn't have the benefit of having a lot of barrier boxes, but we probably minimized infection by having minimal staff present, all wearing PPE, some even wearing PAPR, and we only extubated in a negative pressure rooms, and we avoided use of aerosol generating procedures like the use of NIV. In terms of ECMO, we contribute 6 cases to the entire ELSO registry here. So many patients, of course, throughout the world receive ECMO for COVID-19. In Singapore, it's about the same. But our policies are very consistent with national norms. So we only use ECMO for patients who have very poor PF ratio, less than 85. And also most of our patients, or in fact almost all our patients, had to have undergone prone positioning and neuromuscular blockade before they were even considered for ECMO. And therefore, because we recruited very severe patients into our ECMO treatment programs, our mortality would of course reflect that. In the entire ELSO registry, the mortality was 40%. In Singapore, among our 6 patients on ECMO, 3 unfortunately passed on. So we had a 50% mortality, 50% survival. So in summary, critical and COVID-19 in Singapore was marked by a lot of planning. We were very fortunate not to have tax on our surge capacity, but we still maintain standard practice. We had the opportunity to split space, staff, and supplies into clean and dirty teams. Of course, this was quite resource intensive, but it created conditions whereby patients and doctors all felt very safe, and nurses all, of course, felt very safe working on the front line. We nonetheless created a lot of search plans and also resource limitation plans in case we needed them. And these plans also took into account the longer duration of mechanical ventilation duration. And on the ground, I think most of us avoided excessive overuse of antimicrobials and also avoided use of off-label and also experimental drugs. So I'd like to thank you for your kind attention, and I'm open to questions.
Thank you, Casey. So actually, the slide was from Casey's paper. So I would strongly recommend everyone to read Casey's paper because it's very important to how to manage the ICU well. As you can see in our Butao, even I think they don't have the concept of clean team and the dirty team. Actually, the dirty team should be like isolation. You should not contact the society. Also, I think that's very important in the future. So everyone have question for Casey? Oh, please.
Dr. C, thank you for your excellent talk. I was actually working in the hospital where we have a nosocomial outbreak in Taiwan. So my question is, it's really difficult for us to maintain the dirty team and clean team. And I especially appreciate your comments about for the ease of mind for all the healthcare workers and all the patients, we really need to know that the patient is actually clean. So I want to learn from your experiences, how would you apply the screening or triage policy for all the patients admitted to your hospitals? Do you screen them routinely, and how can you identify those patients who are at risk? And I want to know that are these measures has been changed during the time when you have this the outbreak and when the pandemic is kind of slowing down? Thank you.
Yeah, thanks for the excellent question. I think the key thing is identification of patients that might have COVID-19. I must say upfront that I think we were very lucky to have a lot of testing capability. So our laboratories were basically doing PCR testing round the clock, especially at the first part of the pandemic. And we really tested anybody whom we had just the inkling that this patient might have some COVID-19. So for example, patients with even a bit of ARI symptoms were tested for COVID-19 twice. So they were put in basically general wards, single rooms to be tested, and they were only let out of those rooms if they had 2 samples that were negative. I think this created conditions whereby we probably had very, very, very low rates of COVID-19 positivity, but this was traded off against people being very comfortable to work in a hospital because of a very strict de-isolation procedure. We didn't have any so-called leakage of contaminated patients out of these so-called isolation wards. And but this came at a big cost because we spent a lot on testing.
Okay, thank you. So any other question? So thank you, Casey, again, and hope to meet you soon after the end of the COVID-19 pandemic. Okay, thank you.
Thank you. Thanks. Yeah, stay safe, everyone. Thank you.